There's several different pretty classic presentations of IgG4 related disease. The first one is a mass lesion. The disease is very often misdiagnosed as being a cancer because it presents as a mass lesion in the pancreas, around the eyes, in the major salivary glands, in lymph nodes. So a mass lesion is the classic way that it presents. But it can also present with constitutional symptoms and weight loss in a very subacute way that sort of evolves over a period of months, such that patients lose 10, 15, 20 pounds of weight over that time. And then I would say the third major presentation is atopy, symptoms of allergy, asthma, allergic rhinitis. And we think that is all part of IgG4 related disease, perhaps a down-regulatory inflammatory response leading to those kinds of symptoms. So the tissue is the issue with regard to diagnosis and clinico-pathologic correlation. One has to biopsy an involved organ and review the pathology with a pathologist who has some knowledge of the disease. The histopathology is really the key. The lymphoplasmacytic infiltrate, storiform fibrosis, obliterative phlebitis are the major characteristics. And then all of those can be supplemented by the immunostaining for IgG4 of plasma cells. The traditional treatment thus far has been glucocorticoids, prednisone. The great majority of patients respond to glucocorticoids, but like so many immune-mediated diseases, glucocorticoids don't cure the disease most of the time. So we typically start with prednisone and treat with a 2 to 3 month course, and then if they fail that, then we have to treat with something else. There is very little indication that the traditional steroid-sparing medicines, methotrexate, azathioprine, Cellcept, work in this disease. But what we have learned about the biology of the disease gives us a lot of different new treatment approaches. The disease is really driven by a dance between B cells and T cells. And we think at the heart of the disease is antigen presentation by B cells and plasmablasts to a specific kind of T cell that our group has identified, a CD4 positive cytotoxic T lymphocyte. And interfering with either the B cell side of that, for example, through anti-CD20 therapies, or interfering with the T cell side of that, which has really been unexamined so far, has a lot of opportunity for treating the disease without steroids or more effectively than steroids.